this particular person would be tested for the presence of antibodies here for a variety of reasons. One is the presence of antibodies in itself might lead to some level of problems, which we talked about, antibody related problems as they happen, enhancement in particular in such an individual, or the superfluousness of this particular vaccine eventually. So I believe my take would be to essentially see that all the prospective volunteers for a particular study, could they be, if we just look at the general way in which this can be done, can we actually do this for every single vaccine participant? We can't, because they may not have given this history, but they might be actually having some individuals here who might have been exposed to this particular virus. So eventually we'll end up getting people who, for example, have remained absolutely free from any exposure to the virus. That is one possibility. The second possibility is who might have been exposed to the virus, never noticed the infection, and then eventually got actually immunized by this particular virus. And the third tricky group, what you are talking, is about those who have reported being suffered from COVID here. So my take would be, at least for the third group, just try and ensure the level of sero response in them, and then take the appropriate action about enrollment or not. But Dr. Arora, kindly just tell us about what's happening at the global level among the trials which are already underway.
So there are two issues. One is when we look at the in-file data of various vaccine manufacturers, we see that response to antigen, vaccine antigen, is several folds higher than the natural infection antibody response. And the second information is, and that is from India, and that during the plasmid trial, 30% of the donors, plasma donors, did not have any neutralizing antibody. So, and now there are 2 or 3 vaccine manufacturers who have started including those individuals who have previous evidence of exposure to virus. So at the moment, as you very rightly said, there is no good evidence should be given or not given. But even if I want to do a prior evaluation, it will be a nightmare, a programmatic nightmare, that because about 25 to 30% of our population, in particularly in cities, is exposed to the virus, asymptomatic or symptomatic. So it appears that probably from the national perspective, we will go ahead. We will not test for prior exposure and give vaccine to all the others. If at all, these vaccines, as Pradeep Kumar, Dr. Professor Pradeep has responded, as said, that it will be like a booster for the vaccine. So vaccines will be given to everybody, irrespective of their prior exposure from national perspective.
Thank you very much, sir. We are winding this particular session. I think Professor Purushottam wants to make a comment. Please be very brief, sir. We have no time to. Please be very brief. Purushottam is a professor and head of the Department of Pediatrics, Thrissur Medical College. Purushottam, please unmute yourself. Unmute and please be very brief.
Just 1 minute, sir. Hello. Can you hear?
Please.
Sir, we are not considering the cell-mediated immunity. And pharmaceuticals and vaccine manufacturers will be very much interested to give us an information that vaccine is needed even for those who had this thing. But we should be considering the cell-mediated immunity. All the studies shows that the vaccine antibody will be waning over time. And there are a lot of infections where the antibody may not be there. Still, there's a possibility of immunity. And in that situation, if there is an evidence of the contact with the virus, whatever be the level of the antibody, whether it is very small or not, keep them for the last in the priority. So give the priority the other people and those who had whatever evidence of an infection to the last, rather than not giving the chance of cell-mediated immunity. Cell-mediated immunity also in this case must be contributing very much to the protection. That is to be considered, sir.
Any comments, Sanjay sir? You have some comments? Because
No,
you have not mentioned much about cell-mediated immunity. That might have been thought Purushothaman to make that.
no, that's
question.
fine. I think not much work has been done on cell-mediated immunity, but the kind of papers that have been published also indicate that the cell-mediated responses that are observed are quite, say, sort of in line with what also happens in humoral immune response as well. But as sir rightly pointed out, we will have to wait and watch. Probably more data on cell-mediated immunity will arise from the phase 3 trials, where such kinds of evidences we can more conclusively come to and talk about.
Thank you very much, sir. And thank you. Now I request our former VC, Professor M.K.C. Nair, to introduce Dr. N.K. Because they are very thick friends also. Thank you, sir. Thank you, M.K.C. sir.
Good evening to all. I think it's a great pleasure to introduce my good friend for last maybe 30 years, Professor Dr. Narendra Arora, currently the Executive Director for England International Clinical Epidemiology Network. I think he has led it for last 15 years successfully. When England was going to die down, I think he took the responsibility and held it for last 10-15 years. So that's a great thing. He's also the president of AIIMS Patna, a former professor of pediatric cardiology and pediatric gastroenterology and hepatology at All India Institute of Medical Sciences. Astute clinical researcher, very astute, very practical researcher, and a right person for clinical epidemiology. He's probably the last word in India for program evaluation, because nobody in India has done that many number of program evaluation of governmental programs, and a key policy maker now, particularly in the vaccine, whether to introduce, what to introduce, how to introduce. So probably he's the right person to talk about it. Very simple man, very practical person. I'm expecting him to reach much higher levels in the soon. And I think, let me wish that 2021 is even a higher level, I would say him. Sir, we are really honored to have your speech right now after an excellent basic speech on the whole subject. We understood most of it. And now you are going to come out with more practical questions. Some of this question that was asked actually should have been after his talk, because that, that will get things together. Anyway, Professor Arora, I'm presenting to this august audience.
Thank you very much, sir. Now for Professor Arora's information, Dr. Sudhindra Ghosh, Professor Sudhindra Ghosh, a good friend of you, also is here. And now I request Professor Arora to take the mic.
Okay, thank you very much, MKC. Actually, you're too generous because you are biased and because of our long and great friendship. Thank you very much for that very generous introduction. Can I share the screen and use the slides?
Of course, please go ahead.
Yeah, I will do that. So, good evening, friends. And I would just like to say how honored I feel to be part of this illustrious and distinguished group. And the questions I'm seeing in the chat box are very, very important questions. So I will now talk about basically program related issues and share. Yeah. So can I start? Are the slides visible?
Yes, sir. Very much
Okay.
visible. You can go ahead, sir. Thank you.
Yeah.
Everything
Thank you
is
very
perfect.
much.
Everything.
Yeah. So I will talk about vaccine rollout in India and what have been the consideration and what preparations are going on. And then we can take up clarifications, questions after that. So I will first take you through the process of determining the vaccine prioritization exercise, how the country has decided on prioritization, because the vaccine will not be available. And therefore, we need to have some kind of a very transparent process. So the decision was needed because of the limited availability. I do not know how many would be aware that India would have access to about 600 to 700 million doses by July this year. And so some of our other countries may look ahead, but I think July we will surpass all of them put together, because 600 million doses should have been given by that time. As I said, the decision has to be transparent and based on science and evidence. And decision is to be from a group that is considered credible and that has served Indian vaccine related activities. And so NTAGI made a subgroup and basically the recommendation is from NTAGI, which has been vetted by the highest policy making body on vaccine, which is NETVAG, National Advisory Group on Vaccine Administration, and which is chaired by Professor V.K. Paul. The second is equally important, that the public confidence in vaccination is fragile, and some of the questions I think I have noted down as a qualitative researcher. The issue is to which I should believe, the disease or the vaccine. I think it sums up the whole issue in a very beautiful manner. I think Hariharan has put in this question, and very aptly. So the COVID vaccination program will succeed only if there is widespread belief that available vaccines are safe and effective. Policy for prioritizing their distribution are equitable and evidence-based, and proactive efforts are in place to debunk rumors and misinformation. And so the objective of the whole vaccine rollout, it has to be done in phased. And the public health objective at the moment is reducing the burden of infection and disease, particularly the mortality and hospitalization, severity reduction. At this time, there is no data. And the question Rajmohan is repeatedly asking about the interruption of transmission or herd immunity, and various modeling exercises have been done, are being done. But I would say to all these with a pinch of salt, it is really difficult at this time. What will happen? I'm sure you have heard 2 days ago that there was 0 case in Dharavi in Mumbai. Dr. Sanjay Mahendale is there, and he would tell you Dharavi's human density is highest in the world. It's about 37,000 people per square kilometer. People almost sit on each top of each other. But serology there shows around 58%. 42% are negative. And there are no cases. There may be some improvement in terms of COVID behavior, COVID appropriate behavior. That means mask, distance, and hand washing. But still 42%, why are they kind of not getting infection? Is something to be looked at. So this whole issue of herd immunity and related issues are difficult, and there are so many dimensions. Polio has gone, but we have still not been able to answer this question of herd immunity. The other issue is to take care of the social impacts and the economic impacts, because this vaccine, when recipient prioritization is done, these two are equally important, because right in the beginning, the Vice Chancellor had said that all of us are waiting to resume our normal lives again. So I'll take you through to the last nationwide COVID serology survey. And this was done in August, September, and this week again a nationwide survey is being planned. And I will just draw your attention to this is the one. Adjusted prevalence in adults was 7%, and everybody above the age of 10 was 6.6%. Not much difference between children and when you take everybody together. And this was 10 times increase over the first survey, which was done in the last week of May and first week of June, when it was 0.7%. So initially the seroprevalence, and that means infections or exposure to virus, occurred an increase to 10%. This was done in 70 districts. And now some of the issues that at that time we had only the estimated number based on that 7% was 7 crores. Where is my, yes. .7%. And during the same period, the number of cases were very less, 28 lakhs. So, and clearly we know from each other's experience, and also we know it from overall, that case reporting has been grossly underreported. So Dr. Sanjay told us about the deaths, that we have death is a more valid information or closer to truth. And then we look at case fatality ratio per 10,000, and we find that it is 10 per 10,000 population. So you take out at the basis of total, and you find this is one of the lowest case infection fatality. That means out of those 7.4 crores, if we take 11,000 deaths, then this is what becomes the infection fatality ratio, and which is more kind of considered better, because it takes away the issue of reporting of cases. Now, the third important point was I would draw your attention to this section, and which is very interesting. The seroprevalence in rural areas was 4%. urban non-slum was 8% and urban slums was 15%, which clearly shows a very important dimension of living conditions, one, and also population density. So more dense is the population, more intense is the transmission. And 4, 8, and 16, this is a very nice gradient you can see in the seroprevalence of IgG antibodies. And this is likely. Now the next is mortality. This is as of October 4, 2020. I'm showing not the recent data, but I'm showing the data on which the country took the decision to decide the recipient priority. So you see this portion, which is over 50. This is about 53%. And this is about, so this is above 50, this is 60%. And this is 50%. Together, they constitute 80% of all the mortality which is occurring in the country. Now, that takes care that this is the group which needs to, if we have to reduce the mortality, because mortality in the lower population is much less. Now, this was the paper published in Science, which again showed and convinced the same thing. This was done in 2 states, Tamil Nadu and Andhra Pradesh. And as you see, the mortality starts rising from 50 and keeps rising thereafter, whether it is male or it is female. In both the situations, mortality is rising. Now, let us look at what Dr. Sanjay Mahendale also told us. This is comparison of mortality trend by age in 2 countries. This portion is USA, and this green is India. Now the 2 graphs look very near, but I would draw your attention to this y-axis, which is log. So the death in Indian situation is much higher, although they move parallelly, but every age there is a difference of 10 to 100 times in various, and particularly in the elderly, you can see the difference is much higher. So what we saw that primarily death is there in elderly population. Number 2, seropositivity is more in densely populated population. Number 3, that all age groups have a seroprevalence which is very similar. Across the age groups, seroprevalence is similar. Now let us look at the COVID vaccines. We have large number of vaccine globally, over 50 candidates in clinical phase. In India, also we have 5-6 vaccines. Safety issues have been taken care of. They are pretty safe. No any major significant safety signal has arisen so far. Even in those vaccines which are currently in use, about 3 million doses have been given in other parts with Pfizer and Moderna. The only safety issue has that anaphylaxis rate, which is normally for vaccines, is 1 in 1 million. It appears to be varying between 1 in 0.5 to 1 million. So there are 4, 5, 6 cases of anaphylaxis which have been reported with Pfizer vaccine. And immunogenicity, the data is very good. clinical efficacy, prevention of disease at the moment is not because sufficient time has not been given. What it has shown is the clinical events, the reduced disease, severity and mortality, the occurrence of disease is coming down, will come down with all the whatever data from phase 3 is available, both whatever vaccines are available in India and the others. In elderly population, whatever data is available, it seems vaccine will be workable. Prevent infection, as I said, it is not available. And the other issue, which is very important and all of us are hearing, is program-friendly storage conditions. That's a very important component, and that has to be taken into account when vaccine down selection is to be done. Another dimension of the issue is that when recipient prioritization is done, we have to look at, these are criteria developed by WHO SAGE in September 2020. And basically, these are standard kind of public health principles: human well-being, where you reduce deaths, disease burden, societal and economic disruption, and protect continuing of essential services, including health services. Equal respect. That means treat the interest of all individuals and group with equal consideration, and offer a meaningful opportunity to be vaccinated to all individuals and group who qualify under prioritization. Equity is, all of us are aware. National equity is also important, that countries take into account the vulnerabilities, risk, and need of groups who, because of underlying societal, geographic, or biomedical factors, are at risk of experiencing greater burden from COVID-19. And then immunization delivery system which reaches everywhere. Reciprocity is a very important component, and we have to take care of people who have been taking care of us. That means medical personnel, security personnel, municipal personnel who are maintaining essential workers, and legitimacy. That means the best available scientific evidence, expertise, and engagement of all the stakeholders. So prioritization, when it has been taken, it depends on epidemiological setting, vaccine supply scenario, and then priority groups. Now, under the COVAX, 3 phases have been built up. Phase 1, when very limited availability of vaccine is there, and you can cover only 1 to 10% of the population. And phase 2 is when availability improves, but you can cover only up to 20% of the population. So if in the phase 1, you have health workers, older adults defined by age-based risk specific, and this health workers and other frontline workers, older adult, and emergency reserve for outbreak response. So that means country should have some stocks for mitigation if there is a severe localized outbreak. And then as the things improve, groups with comorbidities and socio-demographic groups at significant higher risk of severe disease. This is the broad principle under COVAX facility. So what India has done. So in India, we have 2 categories: those who are at high risk of exposure, first responders, that means health providers, both in health facilities and field, public and private sector. Police and security personnel involved in implementing non-pharmaceutical interventions, municipal workers. And next, if there is still vaccine, teachers, primary school teachers particularly, because children are not so much affected, but their teachers get affected. So, and primary school teachers are important because cognition of children requires that these children should interact and meet theirs. So when the teachers are immunized, then primary school can be opened up with much confidence, and maintaining other essential services. High risk of poor outcome, I have already shown you that those above 50 years with comorbidities, in fact, in India, the analysis is showing over 90% of people who are dying are some kind of a comorbidity. Those under, so there is a correlation between those who are above 50 years and those and who where death is almost 75 to 80%. And in those who are younger than 50, there also comorbidity is an important parameter. Now, what are the COVID vaccines available in India? At present, 5 vaccines are in phase 1, 2, or phase 3 trials in India. ChAdOx is the Serum Institute of India or the Oxford vaccine. ZyCoV-D, this is DNA vaccine from Cadila Zydus. Covaxin, Bharat Biologicals Limited. So ZyCo-D is an indigenous vaccine. Covaxin is an indigenous vaccine. Then Sputnik V, Dr. Reddy's laboratory, it is a Russian vaccine being manufactured in India. And Biological East novel SARS-CoV-2 vaccine, which is also indigenous vaccine. And so what is the status? COVAX at the moment is the only vaccine which is going a full phase 3 clinical trial in India. The other Indian vaccines, that means Zydus Cadila and Biological E vaccine, will enter phase 3 trial, I think within in the next 2 or 3 weeks. And 2 other vaccines, which are not basically Indian vaccines, but are being manufactured. ChAdOx is by Serum Institute and Sputnik 5 is by Reddy's Laboratory, but interim analysis from phase 3 trials abroad have recently become available. Although for ChAdOx, which will provide the maximum vaccine, which I said Serum Institute is likely to give us up to 500 million doses by June, it has to have an emergency authorization, use authorization from a country of origin, that is UK. And then within a week or 10 days later, India will, because in India, a smaller bridging study have been done. They are, data is available, but the country is waiting for emergency use authorization from the country of origin so that Indian regulators can give. Sputnik, Dr. Mahendel told us that India had some concern about the availability of phase 2 because the number of patients they had done was too less, 48. So 100 cases for phase 2 are being done with the Sputnik. They have completed recruitment, I think this week or next week they will complete. And thereafter, once the results come, regulator will allow them to go to phase 3. And that means bridging study. They will do 1,500-1,600 patients at that time. So that is the current status. The menu available to India at the moment, in those which are in the advanced. I must also say there is an Indian mRNA vaccine, which is going to enter into clinical phase 1 by next week. And so that by May, it should be that phase 3 should be available. They should be able to complete May or June, 30,000 patients they will be able to manage. So I thought that I will share with you the plan country has made for COVID-19 introduction in India. There is operational guidelines. Your the NECVAC, which I said, National Expert Group on Vaccine Administration for COVID-19, is guiding this whole exercise. Steering committees have been constituted at state level, district level, and block level. A very elaborate arrangement that up to block level system has been, because so far India was giving vaccines only to 5 crore individuals, 5 to 6, 2.5 crore birth cohort, and another 3 crore maternal cohort. So that was around 5.5 crores. So 5 to 6 crore people were getting vaccines. And now there is there is a huge adult population which has never been immunized, and in next few months 30 crore adults will be immunized. The first line of immunization will be all adults. So this vaccine will be introduced. Phase 1 will be focused on high risk groups, which we have already talked about. And as I said, 30 crores. Health workers, about 1 crore. Frontline workers, police, army, disaster team, municipal workers, etc., 2 crores. And prioritized age groups, more than 50 years and some less than 50 years who have comorbidity, approximately 26 crores. So goal is to protect people, minimize societal and economic impact by reducing COVID-19 mortality. Now, this is a unique system which has been prepared. This is an electronic digital platform. Primarily, this was developed for monitoring vaccine delivery, not only COVID, but the other vaccines. But on top of that, electronic beneficiary registration, session allocation, authentication, DigiLocker linked document verification, and AEFI reporting system has been built onto this COVID vaccine. So this will be a COVID beneficiary management platform. Vaccine stock management too will go simultaneously, and temperature to see that the vaccines, the quality of the vaccine is maintained, and everything on a digital, and the whole country is covered under this. And there is a dashboard, and with real-time visibility, health worker will be able to visualize real-time stock views, alert on low stock, optimal order recommendation, temperature alarms, SOP reminders, beneficiary vaccination status. I think that is the highlight of this. The vaccine management was there up to now, but beneficiary vaccination, because every beneficiary has to be given 2 vaccines. And so you have to follow them up after 1 and 2nd. Then there was a question that there can be a mix-up, that NK Arora gets 1 brand and MKC Nair gets another brand as first dose, and then in the second dose there is a confusion. To take care of that, the beneficiary vaccination status and monitoring coverage and all these will be done in real time using this platform. Vaccinatory, so how vaccination beneficiary management process will go? There will be registration, sessions will be planned according to that. There will be allocation. You just cannot walk into any session. Every individual will be allocated a session, a site, immunization clinic, and there will be session-wise beneficiary listing. You will be given an appointment. There will be SMS to beneficiary about the session date and sites. Beneficiary validation at session site will be done. Vaccine done and SMS sent to beneficiary. And for the second dose and vaccination certificate, e-certificate will be given on completion of vaccination. So this is, it looks very complicated, but interestingly, this has been done. And I think Monday onwards, tomorrow onwards, a full dress rehearsal is planned in 4 states. And there will be different session types for different priority groups, and session planning for COVID vaccination. Basically, every session site will have 3 rooms: waiting room, vaccination room, and observation room. And because of the COVID, this distance and social distance will be a very important component. And outreach session will include schools, community halls, gram panchayat, basically wherever polling booths are done. And so it is, the whole experience is drawn from mass vaccination campaign for like measles, rubella, or polio, and also election booth approach. So India is using its experience from polio as well as election booth approach. So there will be 5 people, vaccination officer 1, which verifies the individuals. Only registered individuals are allowed. Second person, CoWIN verification of beneficiaries, registers receipt of vaccine. Number 3, administers the vaccine and manages any immediate AFI. Number 3 will be crowd management. And number 4 will be also crowd management and also counsel the unregistered and adherence to physical. Every individual will be asked to wait for 30 minutes. There will be a team supervisor for every 3 to 5 sessions. And so organization, something like this is planned. Reception, screening, waiting, vaccination, post-vaccination, and then vaccination and message and certification. All this looks out of the world, but the system, I have seen this system. The system seems to be working, but a full dress rehearsal is required. Then finally comes the communication. And I must tell you, I feel very nice about this year. Last 25 years experience has been built into developing the communication plan for COVID-19. We have excellent experience and managing those challenges from polio to measles, rubella, and now the COVID. So vaccine hesitancy and all these, the basic principles are that we know there are two things working in different direction. On one side, there is eagerness, and the other is issues of trust and confidence. And then these are 5 components: advocacy, capacity, media engagement, social mobilization, and AEFI. In fact, AEFI surveillance has been already beefed up. And from national to district level, there are over 750 AEFI committees. I'm sure among the audience, there must be members of the either state or district AEFI committees. And the process has started, and I'm given to understand that the state level, they will be expanded by the end of 31st December. And by 15th January, all AEFI committees will co-opt adult physicians, pulmonologists, cardiologists, neurologists, and maybe nephrologists, because these are the organs which are involved. So the vaccination plan information will be given, and it has to be provide correct and transparent and consistent. The basic principle which is now being followed is exceptional transparency. Do not try to hide anything. Vaccine eagerness is to be handled, vaccine hesitancy to be handled, and COVID appropriate behavior is not to be forgotten. I'm so glad that VC started with this issue about COVID appropriate behavior. Target audience will remain, primary will be beneficiaries of all various people. Secondary will be community level stakeholders, various opinion makers, and tertiary will be public figures, media, academicians, bloggers, journals. And then media plan also, whenever it is done, it is again the correct and transparent information and address all these 3 issues. Positive media is to be scanned as well as negative media is to be scanned. Nothing is to be, and not only the national, but vernacular media to be closely looked at, because they have very important role, and ensure strong coordination of media queries and as well as professional queries. The national strategic focus is to reach audience with factual information COVID vaccine and engage them in supporting. So for example, at the moment, all of us know, we do not know the duration of protection this vaccine provides. So be very clear and honest about it. Strategy to be audience centric. And another very important is social media engagement and social listening. Posts and reports will be done. There are now technological methods to monitor social media, be it Facebook, Instagram, WhatsApp. These are very important issues. Advocacy and sensitization of all key stakeholders. Capacity building in communication, because this we have been talking about, and the training for this communication has already started around the across the country, so that this takes care of, because there should be consistent message, and issues of vaccine demand and hesitancy are taken upfront, and if there are issues, it takes care of. And then focus of social mobilization. How are we going to do? You know already that on the media, we are already talking about vaccine hesitancy quite a bit during last 2 weeks. This is part of media campaign. And this is by design, that to make people aware. We knew in Indonesia, this whole problem of halal and haram medicines and vaccine started. This has come up in India also. There was a fatwa 4 days ago, and that is being discussed, and to make it open, not trying to undermine this discussion. And towards the end, I would just say that this all is being done with 20 key ministries are participating at national level, and all possible partners, development and technical partners and professional bodies are part of it. The beautiful part is that so far we thought immunization is the domain of pediatricians, but now it is everybody's domain. Challenges are huge. It looks very nice, but as all of us can understand, challenges are huge. And that's why a pre-rollout pilot is taking place in 4 states. These are full dress rehearsal. There is a massive army-like operation. There might be ifs and buts, and which the country is preparing to take care of it. Because ultimately there is a national commitment that priority recipients should all be immunized by July, August 2020. That means 30 crore individuals or 60 crore injections. Thank you very much.
Thank you. Thank you very much, sir. I humbly request you to stop screen sharing. Okay, thank you very much. Now we have about 15 minutes for discussion, and there are few questions in the chat box. One is about hesitancy, vaccine hesitancy among the healthcare workers. Suppose there is, how you address that issue, because the sensitization of the healthcare workers is more important. Of course, in COVID behavior, appropriate behavior, as well as about vaccine receiving. So there are few people who are ready to take risky behavior. So how you considered that, sir?
So what I would say, that we know that health worker is our first challenge. In H1N1 epidemic in 2009-10, the major hurdle came. The vaccine never distributed because health workers were not convinced. So as I said, one of the key target audience is health providers. They need to be convinced. And if they are convinced, then I think we have won a major part of this fight and challenge. So there are special issues, and systematically that segment has to be targeted. Besides that, the vaccination program will start where everybody will be given vaccine together, because sometimes there are words on a lighter vein, but it is true. I do not know how many of you seen that old movie, Raj Kapoor's movie, Bobby. And there was a song by Pehle Tum, means first you or first you. I mean, two people, the boy and girl telling each other. And that has been the campaign started by some health providers. And they have said that some of them are saying, we will wait, let others get it, and after that we will take it. So pehle tum. So that issue is being taken care of. There is already media kind of scanning, and social media counseling scanning is going on. And as you rightly said, health providers are our first target for demand and hesitancy.
Now, Professor Sanjay has asked a question, sir. Can you please explain what are all the government initiatives to answer those critics who critique in introduction of vaccine in India? Maybe, you know, this is actually the confidence gap, or is other side of confidence gap. This is a criticism by the intellectuals and the scientists. In Kerala, this is especially important.
Yeah, no, it is important all over the country, I must say. So, if I very rapidly brisk through the communication plan, and so target audience, if you had seen, first target audience is the recipients, beneficiaries. Second is community leadership, and third is all these professionals. So these professionals are systematically being will be taken care of, and the process has started. Some of the TV programs you will see some are targeted. At least every day you will see, particularly Doordarshan and some of the, I think, regional language other than English media. It means Tamil, Telugu, Hindi, and all other languages. They are targeting three type of audience: general community, but also professionals. Some of these, particularly those are in English, are for professionals and so-called intellectuals. So there is a initiative, as well as very much cognizance of this value, that they are thought leaders and they need to be on board.
Okay, thank you very much, sir. And now we have about 10 minutes for a discussion. Anybody who wants to make a comment, because I don't find any questions in the chat box. Maybe it is very clear. Most of the things are very clear. Anybody wants to make
Dr. Sairu Philip has raised her hand in between.
Okay.
Yes, Sairu, please go ahead.
Dr. Sairu? Sairu, please unmute yourself. Please unmute yourself. You are muted. Oh, it was accidental. Oh, no problem. But you can still make comments. Professor NK is so friendly and known to all of us. He's a friend of all of us. Sairu, you are a member of NK's team. Professor Sairu is not making any comment. In
So
that case,
I thought I will make a comment based on previous one. Okay.
Yeah, sir.
So in fact, yesterday also and Doordarshan, I made that comment. This whole issue of public perception of speed of development of vaccines. So there are three components. One is, usually the scientist and the industry works from 9 to 5. But during last 1 year, I'm sure many of us present here also have been working 5 a.m. to 9 p.m. And it is already 9 p.m. today also. So there is an extra effort, one. Number two, it's a management structure, management and efficient management has been brought into. So those activities which used to take months and years have been crunched into weeks. And parallelly, several activities were taken up. The important point is, not even a single corner has been cut. In the initial, if you look at, none of us were aware that there is phase 1, phase 2, phase 3, or most of us were not aware. And similarly, we were not aware what happens in preclinical. But today, what has happened is, in phase 1, for example, and phase 2, normally 50 or 100 individuals were taken as the subject participants. Today, most of these studies have 300 to 1,000 individuals in phase 1 and phase 2. Second, that phase 3 is all exactly around the same 25,000 to 45,000. That's the usual sample size. And in every phase 3, this is the sample size which is being followed across the globe. So there is no cutting out. But how this movement has taken place? Previously, regulators will take 6 months to sit on a file and give you the clearance. Today, they give you the clearance in 6 hours or maximum a day. So there is a 24/7 work is going on, that from phase 1, the data review is on a rolling basis. So from as soon as the data gets accumulated, you keep on submitting it to the regulator. It allows you from moving from phase 1 to phase 2, phase 2 to phase 3 in a seamless manner, and their what is called subject expert committees are functional all over. Our own committee was set up in August 3rd week. And today, December is still not over, and we had 14 meetings in this short period, 4 months or so. So this is just an example that the everything has been on a fast mode, but there is no cutting. There is one caveat there, and that I will make it upfront, and that is that safety issues, most of the side effects, adverse events occur within first 6 to 8 weeks. After that, it is extremely uncommon. But the durability of protection, as Dr. Sanjay was also saying, it requires 1 to 2 years. We know the protection available for in 2 to 3 months. So when we see 95% for Pfizer or 67% for Chadox or Oxford vaccine, that means within that much period, this efficacy was, it was protecting so many cases, symptomatic cases. So over the time, and it is also the whole issue will be all these phase 3 trials will continue, and up to 1 year they will come to know, and that will give us a better idea about the durability or the duration of the protection. But at the moment, it looks like the modeling exercise is suggesting that the duration will be at least for 9 to 12 months, the antibodies and the way some weaning exercise. But this is too preliminary. It may be completely wrong. I see a comment about availability of vaccine in open market. The government has not taken a clear-cut decision, but there is still a possibility that it will not be available for phase 1. That means when priority recipients, because the reason is that everybody fears intense black marketing. We already know there is a vaccine tourism taking place. People are advertising that they will take you to US or UK and get the vaccine. So, and in the process, that whole issue of equity, equal distribution, respect, all those things are likely to go. So there is a possibility that first priority recipients will get vaccine, and thereafter, depending on the availability. But I must tell you, the way India is going, India will never be short of vaccine. We will have plenty of vaccine, the way capacities are there. Sanjay and myself both are in those committees which have seen the data, and the vaccine volumes will be available. But not only that, I think we should be able to take care of all our neighbors, including a lot of poor countries or low and middle income countries in Africa, our friends there. So this is a great opportunity for health diplomacy for India as well.
Thank you very much, sir. I think one question is again coming, that is whether you will vaccinate those healthcare workers who have been already infected.
Currently, I would say that it is a programmatic nightmare, and there is you do what is that techno financial feasibility. The cost of checking and then giving is more, and the confusion it will cause. So at the moment, there are no exclusion criteria of those who have got an infection. But somebody who has got an infection and decides not to come, it will be their choice. But at the moment, there are no contraindications.
Now, there is a question about the logistics of vaccine delivery in the community. Suppose one person has missed the dose, what will be the arrangement? There is a question.
Yeah, so there will be always a possibility they will have to take a reappointment. It's everything is by appointment. A lot of people will forget because they will get a SMS and all those, still that they will forget. But the important thing is, if you take vaccine from a particular booth in Trivandrum, you can't get that vaccine from Kochi. It will be from the same booth.
Okay, sir. Thank you very much. Now, Sairu, unfortunately, Sairu had to exit from the session because of some personal problems. He has made a comment that is about the public health aspects of prevention other than vaccine. How we are boosting that aspect to be continuing with the vaccination efforts?
They will be the underpinning of all interventions: mask, distance, and hand sanitization. And actually, all of us are clinicians. I think most of us I see are clinicians here and public health people, adult and the others. That during last 1 year, URI has practically disappeared from our clinical practice. So this practice by itself is a hugely beneficial. It might benefit the measles and rubella epidemic. It will help even the other tuberculosis and those kind of spread of this disease. So this is important not only from this. So the only thing is that social interaction is likely, these are good habits and which will have it will continue to be emphasized, because that is why one of the key pillars of one of the 3 pillars of the whole communication strategy is COVID appropriate behavior. That is not going to go. You will continue to hear these celebrities on telephone every time you call up anybody.
Thank you, sir. Sir, one question about the allocation of vaccine to different states. Dr.
Yes.
Seshadri is interested to
Yes.
know about it.
Yeah. So there are 2 or 3 questions. One is to allocation to different states. Sapna KG has, sir, we have heard that Oxfam vaccine trial not yet restarted. No, it is not correct. They have almost completed. The file is lying with the European regulator. I think it's the problem. It is not yet started. Is about, I think, half dose. It is not full dose. Full dose thing is completed. Thomas is asking about explain the process of the dress rehearsal. Hello, Thomas. Nice to see you here. You just switched off your video also. So the dress rehearsal is in terms of starting from the vaccine, central vaccine store, how things will move up to the arm of an adult when the vaccine is given. So all those things, parameters will be taken care of. The second thing is, the second issue is about how states will get it. States have already been asked to register people, all the states, about medical personnel, about security personnel, municipal, and I think very soon the next step is registering or making line list of those who are above 50. That process, and accordingly the vaccine will be transferred to every block. That is why up to the block level, steering committees will be formed. There is this question about reinfection. Reinfection is very uncommon. I think forget about it. For practical purposes, it has been overhyped. Every vaccine, every disease can occur again, but it is rare. Yeah, I mean, as we see in those who are little immunocompromised, measles or rubella also, there may be a milder kind of thing. So I think it is overhyped. It's not an issue, major issue. I would not say from either clinical or public health point of view.
Good evening, sir. This is Thomas Matthew.
Hi, Thomas.
Sir, no such dress rehearsal or dry trials were done in any other vaccination campaigns. So how exactly this will help us in countering the criticism or the apprehensions?
So basically, for the first time, adults are being immunized, and adults, children, poor children, and women are what I would say underprivileged. They can't complain of anything. So we know that adults, when they are being given vaccine, they will have all the complaints, and that we have already. So the system is getting geared for that. But the more important is dynamics, how to use this digital platform, how to ensure there are no stockouts, how the booth system works, how individuals will be given first certificate and second certificate for the vaccination. All those issues are to be tested before one goes into full-fledged rollout.
Sir, thank you very much, sir.
Sir, one question.
I think I have to stop because it is already late. I request our PVC Dr. Vijayan to wrap up the session. And
okay, thank you. We had 2 excellent sessions on the biological basis of vaccine use of COVID and the epidemiological basis of vaccine use. The lot of points, a lot of doubts were cleared, and a lot of happy points also were shared. But I think from the talk of Dr. Sanjay Mehendale, we had 2-3 have very interesting points. Cases per million population is very low in India. That is a very happy news. And another thing is the Coalition for Epidemic Preparedness. Yes, that is the India is taking lead. These are the 2 very, very happy happy informations that we had, and we studied extensively about the various vaccine platforms, different types of vaccines, and about the new virus mutation also. Even though there were many informations which are not known, yes, all the latest information about these things were shared by Professor Mehendale, and the discussions that followed. Yes. What is the right time to introduce vaccine? Yes. Still, we are not very sure. We have to be very vigilant about the safety, efficacy, and the immunogenicity of vaccines. We are almost confident now, and yes, the phase 3 trials are almost going to get completed. So we are almost about to start the vaccination process. And yes, he answered about the carriers and vaccine receptors, but we have to wait for getting a final answer about this. Then whether the vaccine will produce some untoward effects like hyperinflammatory situation in children. Yes. And the concerns like whether elderly people, children. I was going to ask whether what about pregnant women. Yes, these are all some of the concerns we are having. Again, the final word we cannot say now because we have to wait for the vaccine trials, large vaccine trials, and the post-vaccination, post-marketing surveillance also is needed to answer all these questions. Yes, which one I should accept? Which vaccine? Yes, I think after the talk of Professor Arora, we are now aware that we don't have such choices. Everything will be decided by the government, right from registration till certification. We will have to go into our own booths, just like going for our voting. We have to go to our own booths and accept it. So we don't have any choice. And most probably the vaccine will not be available in open market soon. That is what we learned from this discussion. Then our Vice Chancellor was asking, can we take more than one type of vaccine? That also was answered very well. Yes, we have to, first aim is to make coverage as much as possible. So an individual may not get two types of vaccine. Then COVID survivors, whether they need vaccine or not. Again, final answer about this is not yet available, but Dr. Arora made it very clear that response to antigen is better than the natural response. That is what Professor Arora said. So we may have to, in future, we may have to adopt a policy, just like in the case of hepatitis B vaccine, where we estimate the antibody level, and if the antibody level is low, we may have to go in for vaccination. Such things we may have to expect in future. Then cell-mediated immunity, yes, that was also mentioned, but now we are sure that it is evident that the cell-mediated immunity, no such studies are available right now. And the epidemiological side, Professor N.K. Arora made it very clear, without any doubt, without any scope for any doubt, how the vaccination plan is made by Government of India, how the prioritization is given, and for the priority groups, health workers, police, municipal workers, teachers, then essential services. Yes, that he made it very clear. Then high risk and poor outcome. Yes, such they will also get prioritized, and the different types of vaccines likely to be available in near future by July 2021. And the more interesting was the clear-cut plan made by the National Expert Group, right from registration to certification. Each booth will be having the waiting place, the vaccination place, vaccination room or an observation room, and everybody will be observed for 30 minutes. And the booth system well planned. And the challenges are huge, and the different modalities that were planned to address these challenges. How to address public, how to address professionals, how to address leaders, anti-vaccine propaganda. Yes, we cannot expect that all health workers will be innovators. As Professor Arora pointed out, pahaletum, maybe the attitude of several people may not be like aha maha mihadiya. Okay, so almost all the queries were answered very well, and I think we are having a very clear picture about the plan of Government of India, and probably India may be able to help the neighboring other nations also. That is also a very good and glad news for us. I think I have covered almost all the points, but I think I was expecting a large number of questions, but in the chat box, but the questions were not that much because the presentation was very clear and we could understand it very well. Thank you. From my point, I am expressing our gratitude towards the speakers, Professor Mehendale and Professor N.K. Arora. Thank you. Thank you very much.
Thank you very much, sir. I think the take-home message today is the most inspiring words of both speakers, that India will be the global leader. because COVID is giving us a wonderful opportunity. Of course, it's a painful opportunity, but more than any time in the life, this is a test of our solidarity. And we hope the words of Professor M.K. Arora and Professor Sanjay Mahandale, great public health persons, as well as the epidemiologist, will become a truth. And now I request Dr. Manoj Kumar, our respected registrar, to offer the formal vote of thanks.
Hello.
Hello.
Sir. Sir.
Thank you.
So, Honorable Vice Chancellor, Dr. Professor Mohan sir, respected PVC sir, MKC sir, and all dignitaries, the participants, very good evening. I was observing both the class, even though I am in outside. Both the class I have sent the discussions and the concluding remarks of the PVC also. So in the late numbers, let me, on behalf of the university, let me extend my sincere gratitude for giving the wonderful evening to both the speakers, the distinguished invitees, professors, principals, and all participants. Thank you very much. Good night, one and all. Over to you, sir.
Thank you, sir. This will be available in the YouTube also. Everybody can view it. I hope most of the faculty may be viewing this, because I had a lot of calls, inquiries about this particular one. This is actually the most important of the series of COVID-related webinars we had. And I once again, on behalf of the university and our Honorable Vice Chancellor, I am thanking Professor Arora MK, who is one of our most dearest friends, and also supporter, and Dr. Sanjay Mahandale, and all other eminent faculty who are present here and who participated in the discussions. Thank you very much. Good night. I am requesting, with the permission of the Honorable Vice Chancellor, I am requesting our IT supporter to stop the program.